Alzheimer's disease is a progressive neurodegenerative disorder that represents the most common cause of dementia in older adults. In older adults, it is characterized by a gradual decline in cognitive abilities, particularly memory, language, and executive functioning, eventually impairing a person's capacity to maintain independence as life expectancy increases worldwide. The prevalence of Alzheimer's disease continues to rise, making it a critical public health issue with profound personal, societal, and economic implications. The hallmark feature of Alzheimer's disease is cognitive decline, with memory impairment typically emerging as the earliest and most prominent symptom. Individuals in the early stages often struggle with episodic memory, the ability to recall recent events or conversations, while older remain intact. Initially, this pattern is consistent with the underlying neuropathology of the disease, which begins in the medial temporal lobe, particularly the hippocampus, a region crucial for forming new memories. Over time, the pathology spreads to other cortical areas, resulting in broader cognitive deficits. As the disease progresses, additional cognitive domains become affected. Language impairments emerge, often starting with word-finding difficulties. Anomia, progressing to reduced fluency and impaired comprehension. Visuospatial deficits may also appear, leading to disorientation, difficulty recognizing familiar places, and problems with spatial navigation. Executive functions, such as planning, reasoning, judgment, and task flexibility, gradually deteriorate, impairing the ability to manage finances, follow multi-step instructions, or adapt to new situations. These deficits culminate in significant functional decline, necessitating increased caregiving and, eventually, full-time care. The cognitive decline seen in Alzheimer's disease reflects a cascade of underlying neuropathological changes. Two core pathological hallmarks define the disease: extracellular amyloid beta, AB, plaques, and intracellular neurofibrillary tangles, composed of hyperphosphorylated tau protein. Amyloid plaques disrupt synaptic communication, while tau tangles lead to the collapse of microtubule structures, essential for neuronal integrity and function. Together, these abnormalities result in synaptic loss, neuronal death, and widespread cortical atrophy. This neurodegeneration follows a predictable pattern. initially affecting the hippocampus before advancing to the parietal and frontal lobes, aligning with the evolving clinical symptoms. Neuroimaging studies provide valuable insights into these changes. Structural MRI commonly reveals hippocampal atrophy and global cortical thinning in affected individuals. Functional imaging techniques, such as FOGPATE, show reduced glucose metabolism in temporoparietal regions, while amyloid and tau PET tracers enable in vivo visualization, offering potential diagnosis. Cognitive decline in Alzheimer's disease also intersects with disruptions in neurotransmitter systems, particularly acetylcholine. The cholinergic system, which is essential for memory and learning, is notably impaired due to the degeneration of basal forebrain cholinergic neurons. This insight has guided pharmacological treatment approaches. Cholinesterase inhibitors, such as donepezil, rivastigmine, and galantamine, work by increasing synaptic acetylcholine levels and have demonstrated modest maintenance and improving behavioral symptoms. Another class of medication, NMDA receptor antagonists like memantine, is used in moderate to severe stages to modulate glutamatergic activity and reduce excitatory, while current treatments offer symptomatic relief. They do not halt or reverse the disease process. Consequently, research is increasingly focused on early detection and intervention. The concept of mild cognitive impairment, McKee, particularly the amnestic subtype, has gained prominence as a prodromal stage of Alzheimer's disease. Individuals with McKee exhibit noticeable memory problems without significant functional decline and are at elevated risk. Early identification allows for intervention at a stage when neurodegeneration is less advanced and potentially more modifiable. Recent advances in biomarker research aim to detect Alzheimer's pathology before clinical symptoms arise. Cerebrospinal fluid (CEF) analysis showing decreased AB42 and increased total and phosphorylated tau levels, alongside amyloid and tau PET imaging, provides robust diagnostic tools. Emerging blood-based biomarkers may further enhance early diagnosis and screening capabilities in primary care settings. In addition to memory loss and cognitive impairment, behavioral and psychological symptoms frequently accompany Alzheimer's disease. These may include apathy, depression, anxiety, irritability, and, in later stages, psychosis, or agitation. Such symptoms complicate care and often increase caregiver burden. Non-pharmacological interventions, including cognitive stimulation, exercise, social engagement, and environmental modifications, play a vital role in comprehensive care plans. In summary, Alzheimer's disease is a complex, progressive disorder that primarily affects memory and cognition, but ultimately compromises all aspects of mental functioning. Its clinical trajectory reflects the gradual spread of pathological changes in the brain, starting in memory-related regions and advancing to widespread cortical systems. Understanding the mechanisms of cognitive decline in Alzheimer's disease informs diagnostic strategies, guides therapeutic interventions, and highlights the importance of early detection in the condition. Ongoing research continues to seek effective disease modifying treatments and preventive measures, offering hope for future advances in care and quality of life. Aphasia is a language disorder that results from damage to the brain regions responsible for producing and comprehending speech. It affects a person's ability to communicate, often impairing speaking, understanding, reading, or writing, while leaving other cognitive functions. Most commonly, aphasia arises following a stroke, but it can also occur due to traumatic brain injury, tumors, or neurodegenerative diseases. The nature and severity of aphasia depend on the location and extent of brain damage, leading to several distinct clinical subtypes that are closely linked to underlying neuroanatomy. The classic framework for understanding aphasia comes from the model developed in the 19th century, which identified specific cortical regions associated with different functions. Chief among these are Broca's area, Wernicke's area, and the arcuate fasciculus, a bundle of nerve fibers connecting them. Broca's area, located in the posterior inferior frontal gyrus of the dominant, usually left, is associated with language production. Damage to this region results in Broca's aphasia, also known as non-fluent or expressive aphasia. Patients with this type have halting, effortful speech, characterized by short utterances, poor grammar, and limited vocabulary, but relatively preserved comprehension. They are often aware of their deficits, which can lead to frustration. In contrast, Wernicke's aphasia, or fluent aphasia, results from damage to the posterior superior temporal gyrus. Individuals with Wernicke's aphasia typically produce fluent, grammatically correct speech that lacks meaning due to the insertion of nonsensical words and neologisms. Comprehension is severely impaired, and patients are often unaware of their deficits, which differentiates this type from Broca's aphasia. While the speech may have normal rhythm and prosody, it conveys little meaningful content, making effective communication difficult. Another well-recognized type is conduction aphasia, which arises from damage to the arcuate fasciculus, the white matter and Wernicke's area. This results in relatively preserved comprehension and fluent speech, but marked difficulty in repetition. Patients often struggle to repeat even simple words or phrases, despite understanding them and being able to speak otherwise. This disconnect highlights the importance of the arcuate fasciculus in integrating language production and comprehension. Global aphasia represents the most severe form, typically resulting from extensive damage to the perisylvian region of the dominant hemisphere. Individuals with global aphasia have profound impairments across all language domains: speaking, comprehension, reading, and writing. Speech output is often limited to a few utterances, or even a complete loss of speech, and comprehension is markedly reduced. This type is frequently associated with large middle cerebral artery strokes and carries a poorer prognosis for recovery. Other variants include transcortical aphasias, which resemble Broca's and Wernicke's aphasias, but with a key distinction: the ability to repeat remains intact. Transcortical motor aphasia, associated with damage to the frontal lobe regions, anterior or superior to Broca's area, presents with non-fluent speech and good comprehension, but preserved repetition. Transcortical sensory aphasia, linked to lesions in the temporo-parietal junction outside Wernicke's area, results in fluent but meaningless speech. These patterns suggest that the perisylvian cortex is crucial for repetition, and lesions outside this zone can spare the relevant circuits. Anomic aphasia is a milder form characterized by word finding, difficulties in the context of otherwise fluent and grammatically correct speech. Comprehension and repetition are typically intact, but patients often struggle to retrieve the correct words, leading to vague or circumlocutory speech. This type of aphasia may result from a variety of focal or diffuse lesions, particularly in the left temporal or parietal lobes. Modern neuroimaging has expanded our understanding of aphasia beyond classical localization. Studies using functional MRI and diffusion tensor imaging have shown that language function is distributed across large-scale networks involving both cortical regions. The dual-stream model of language processing posits a dorsal stream for speech production and a ventral stream for comprehension, involving not only Broca's and Wernicke's, but also glia and basal ganglia. These findings challenge the traditional notion of isolated language centers and emphasize the role of connectivity and network dynamics in language function. In clinical practice, identifying the type of aphasia through language assessment helps guide rehabilitation strategies and prognosis. While some patients experience spontaneous recovery, especially in the acute post-stroke phase, most benefit those structured speech and language therapy tailored to their specific deficits. Emerging interventions such as constraint-induced language therapy and neuromodulation techniques like transcranial magnetic stimulation are being explored to enhance recovery by promoting neural plasticity in language networks. Understanding aphasia through the lens of neuroanatomy provides a window into the brain's language architecture. Each subtype reflects the disruption of specific neural circuits, offering insight not only into clinical diagnosis and treatment, but also into the fundamental organization of human language. Autism spectrum disorder, ASD, is a neurodevelopmental condition characterized by persistent deficits in social communication and interaction, alongside restricted. The term spectrum reflects the wide variation in symptoms, abilities, and severity across individuals. While behavioral criteria form the basis for diagnosis, growing research in neuropsychology has illuminated the underlying cognitive profiles and neural mechanisms associated with ASD. These insights help explain the diverse manifestations of the condition and inform targeted interventions. Neuropsychological functioning in individuals with ASD is highly heterogeneous, but several domains frequently show patterns of atypical development. Social cognition, particularly theory of mind, the ability to attribute mental states to others, is among the most consistently affected domains. Many individuals with ASD struggle to understand others' intentions, beliefs, and emotions, leading to difficulties in perspective taking, interpreting social cues, and engaging in reciprocal social interactions. Neuroimaging studies have linked these deficits to atypical activation in brain regions such as the medial prefrontal cortex and temporal sulcus, and in social inference, which are involved in verbal language and communication abilities, vary widely in ASD. While some individuals are nonverbal, others demonstrate fluent speech with unusual prosody or pedantic language. Pragmatic language. The use of language in social contexts is particularly affected. Individuals may have difficulty understanding sarcasm, idioms, or conversational norms, leading to awkward or one-sided communications. Neuropsychological assessments often reveal relatively intact vocabulary and grammar alongside impairments in higher-order language functions such as narrative coherence and inferencing. Executive function. The broad set of cognitive processes involved in planning, flexibility, inhibition, and working memory is another area commonly implicated in ASD. Many individuals exhibit challenges in shifting between tasks or mental sets, which can contribute to the insistence on sameness and difficulty coping with change. Inhibition of prepotent responses may also be impaired, leading to impulsivity or difficulty regulating in social contexts. Working memory deficits, particularly in the verbal domain, can impact academic performance and daily functioning. These executive difficulties are thought to arise from atypical functioning in frontostriatal circuits and reduced connectivity brain regions. Sensory processing differences are also integral to the neuropsychological profile of ASD. Many individuals exhibit hyper or hypo-responsiveness to sensory stimuli, such as lights, textures, or smells. These atypical sensory experiences can contribute to anxiety, distractibility, and behavioral outbursts. Neurophysiological studies, including EEG and MEG, have demonstrated altered patterns of sensory gating and cortical excitability, suggesting that the sensory systems in ASD process information differently from typical brains. Attention and perceptual functioning in ASD often reveal a unique cognitive style. While some individuals show deficits in sustained attention or are easily distracted, others display a heightened focus referred to as weak central coherence. This term contributes to strengths in the powers, which can contribute to strengths involved. Neuroimaging supports this dissociation, showing enhanced activity in posterior perceptual areas and reduced integration with prefrontal regions. Memory functioning in ASD presents a mixed picture. While rote or associative memory is often intact or even enhanced, individuals may struggle with autobiographical or episodic memory. The recall of personally experienced events with contextual richness, difficulties in binding contextual details, or constructing coherent narratives may underlie these challenges. This pattern reflects differences in medial temporal lobe structures and their interaction with the default mode network, which is involved in self-referential thinking and mental time travel. Importantly, neuropsychological strengths in ASD are also well documented. Some individuals exhibit exceptional abilities in areas such as mathematics, music, or visual spatial reasoning, often termed isolates of ability or savant skills. These strengths are believed to stem from enhanced perceptual processing, superior memory for detail, and intense focus-circumscribed interests and circumscribed interests. Recognizing and supporting these strengths is crucial for fostering self-esteem and maximizing functional independence. Assessment of neuropsychological functioning in ASD requires a comprehensive and individualized approach. Standardized testing should be complemented with observations across settings, caregiver interviews, and adaptive behavior measures. Understanding the cognitive profile of an individual with ASD is essential for developing personalized educational plans, therapeutic goals, and accommodations that support learning and social integration. In conclusion, autism spectrum disorder involves a complex neuropsychological profile that spans strengths and challenges across multiple cognitive domains. Deficits in social cognition, executive function, and language coexist with areas of preserved or enhanced functioning, such as perceptual processing and focused attention. These patterns reflect underlying differences in brain structure, connectivity, and function, highlighting the importance of a nuanced strength and intervention. Continued research into the neuropsychology of ASD holds promise for refining diagnostic practices, tailoring interventions, and ultimately improving outcomes for individuals across the spectrum. Brain imaging techniques have revolutionized neuropsychological research by providing powerful tools to visualize and understand the structure and function of the human brain in vivo, when vivo. These technologies enable researchers and clinicians to explore the neural correlates of cognition, behavior, and neuropsychiatric disorders with increasing precision. by linking brain anatomy and activity to specific cognitive functions and deficits. Brain imaging has become essential for both basic neuroscience and applied clinical neuropsychology. Structural imaging techniques, such as magnetic resonance imaging (MRI) and computed tomography, provide detailed information about the anatomy of the brain. MRI, in particular, offers high-resolution images without ionizing radiation, making it ideal for repeated use in research and clinical settings. It allows for precise measurement of cortical thickness, brain volume, and structural abnormalities, such as lesions, tumors, or atrophy. In neuropsychological research, structural MRI is often used to investigate brain behavior relationships by correlating regional brain volumes with cognitive performance. For example, reduced hippocampal volume is consistently associated with memory impairments in conditions like Alzheimer's disease and temporal lobe epilepsy. Scans, while less detailed than MRI, are faster and more widely available. They are often used in acute medical settings to detect hemorrhages, strokes, or traumatic brain injuries. Though limited in their resolution and sensitivity to subtle changes, scans remain valuable in situations where MRI is contraindicated or unavailable. Functional imaging techniques go beyond structure to capture brain activity and metabolism. Functional magnetic resonance imaging (MRI) measures changes in blood oxygenation associated with neural activity, allowing researchers to identify which brain regions are in specific cognitive tasks. This method has become a cornerstone of cognitive neuroscience, enabling the mapping of language, memory, attention, and emotional processing in both healthy individuals and clinical populations. For example, fMRI studies have shown altered activation patterns in the prefrontal cortex of individuals with attention, shedding light on the neural basis of executive function deficits. Positron emission tomography, PET, and single photon emission computed tomography. SPECT are nuclear imaging techniques that assess brain metabolisms by tracking radioactive tracers. PET is particularly valuable in studying neurodegenerative diseases by using tracers that bind to amyloid plaques or tau protein. PET can detect Alzheimer's pathology years before clinical symptoms emerged. SPECT, while similar to PET, is less expensive and more accessible, though it provides lower spatial resolution. Both techniques are instrumental in understanding the neurochemical underpinnings of psychiatric and neurological conditions, including depression, schizophrenia, and Parkinson's disease. Diffusion tensor imaging, DT, is a specialized form of MRI that maps the diffusion of water molecules along white matter tracts, revealing the integrity of neural pathways. This technique is particularly useful for studying brain connectivity and has advanced our understanding of conditions involving white matter disruption, such as multiple sclerosis, traumatic brain injury, and developmental disorders. Dye has shown, for example, that reduced fractional anisotropy in the corpus callosum is associated with impaired interhemispheric communication and cognitive deficits in Tibet patients. Magnetoencephalography, leg and electroencephalography provide exceptional temporal resolution, capturing brain activity on the millisecond scale. It measures electrical activity via scalp electrodes, while leg detects magnetic fields generated by neuronal activity. These techniques are crucial for studying the timing of cognitive processes and identifying abnormal brain rhythms in epilepsy and sleep disorders. Although their spatial resolution is limited compared to MRI or PET, their high temporal precision makes them ideal for neural processes such as attentional shifts or language comprehension. And each imaging modality has its strengths and limitations, and increasingly, researchers combine multiple techniques to gain a more comprehensive understanding of brain function. Multimodal imaging, such as combining fMRI with DT or EEG with MRI, allows for the integration of structural, functional, and temporal data, providing a behavior. Brain imaging has also facilitated longitudinal studies that track neural changes over time, offering insights into brain development, aging, and the progression of neurodegenerative diseases. These studies help identify biomarkers for early diagnosis and monitor the effects of interventions, from cognitive training to pharmacological treatments. In conclusion, brain imaging techniques have transformed neuropsychological research by providing detailed and dynamic views of the brain's structure and function. From mapping cognitive functions to diagnosing neurological conditions, these tools continue to deepen our understanding of the brain and guide the development of targeted interventions. As imaging technology advances, its integration with genetics, artificial intelligence, and computational modeling promises even greater insights into the complexities of human cognition and mental health. The intricate relationship between brain function and human behavior lies at the heart of neuropsychology, a discipline that bridges neuroscience and psychology. Underpin structure and activity underpin cognition and behavior. At its core, neuropsychology seeks to understand how localized brain damage, neurodevelopmental anomalies, or degenerative conditions impact mental functions ranging from language to the decision. Decades of research have demonstrated that the brain operates not as a monolithic entity, but as a network of specialized regions, each contributing uniquely to behavior. The prefrontal cortex, for instance, plays a critical role in executive functions, such as planning, impulse control, and social behavior, while the hippocampus is essential for consolidating new memories. When these areas are disrupted, whether through trauma, stroke, or disease, specific behavioral changes often emerge. For example, damage to the ventromedial prefrontal cortex can lead to impaired emotional regulation and socially inappropriate behavior, while hippocampal damage results in profound anterograde amnesia. One of the most illustrative cases in neuropsychology is that of Phineas Gage, a railroad worker whose frontal lobe injury in the 19th century led to dramatic personality changes without a loss or sensory function. This early case provided compelling evidence for the localization of brain function and its behavioral correlates. In modern times, advancements in neuroimaging techniques, such as fMRI and PET, have allowed for non-invasive mapping of brain activity during various cognitive testings. Neuropsychological assessments further aid in delineating brain behavior relationships by identifying specific cognitive deficits and linking them to neural dysfunction. These standardized tests, ranging from verbal memory, recall to problem-solving tasks, are essential not only for diagnosis, but also for rehabilitation planning. For instance, in patients with Alzheimer's disease, neuropsychological profiles often reveal early impairment in episodic memory corresponding with medial temporal lobe atrophy. Moreover, the field acknowledges that behavior is rarely determined by isolated brain regions. Instead, distributed neural circuits often work in concert and damage to connecting pathways, such as in diffuse axonal injury, can produce complex realization. This network perspective has shifted neuropsychological paradigms, promoting models that emphasize dynamic interactions between cortical and subcortical structures. Importantly, brain behavior relationships are influenced by developmental and environmental contexts. Children with neurodevelopmental disorders, like autism spectrum disorder, or ADHD, show divergent neural maturation patterns that manifest in distinct behavioral phenotypes. Similarly, neuroplasticity, the brain's ability to reorganize itself in response to injury or learning, underscores the dynamic nature of these relationships. Rehabilitation strategies, such as cognitive training or behavioral therapy, leverage this plasticity to promote functional recovery, illustrating the bidirectional interplay between neural systems and behavior. In sum, neuropsychology provides a powerful lens through which we understand the biological basis of human thought and behavior. By integrating clinical observation, experimental research, and neuroimaging data, the discipline continues to refine our understanding of how brain systems support the rich area of human experience and of your experience. Multiple sclerosis (MIS) is a chronic autoimmune disease that attacks the central nervous system, characterized by demyelination, inflammation, and neurodegeneration. While MIS is traditionally known for its physical symptoms, such as muscle weakness, spasticity, and coordination difficulties, it also produces significant cognitive and emotional disturbances that profoundly affect life. These non-motor symptoms can occur early in the disease course, sometimes even preceding physical disability, and may progress independently of motor decline. Cognitive impairment affects approximately 40-70% of individuals with MIS, although severity and specific deficits vary widely. The most commonly impacted cognitive domains include information processing, speed, attention, memory, and executive function. Processing speed deficits are often the earliest and most prominent cognitive signs, manifesting as slowed thinking, difficulty keeping up with conversations, and prolonged response times. This slowing can affect almost every aspect of cognitive functioning, making daily activities more challenging and mentally exhausting. Memory impairments in MIS primarily involve difficulties with retrieval rather than encoding, suggesting a breakdown in access to stored information rather than its initial acquisition. Patients often report forgetfulness and challenges with recalling names, appointments, or previously learned materials. Working memory, the ability to hold and manipulate information over short periods, is also frequently compromised, contributing to difficulties in complex decision-making or multitasking. These issues are typically linked to lesions and atrophy in key brain regions such as the hippocampus and frontal lobes, as well as disrupted connectivity within white matter. Executive function deficits are another common feature, affecting skills such as planning, organizing, abstract reasoning, and problem solving. These impairments may interfere with professional performance and daily life management, such as handling finances or navigating new environments. The underlying neural basis includes demyelination and axonal damage in the prefrontal cortex and its connections with subcortical structures, such as the thalamus and basal ganglia. Attention difficulties in misses can manifest as distractibility, trouble focusing, and reduced mental stamina. These attentional challenges often interact with other cognitive deficits and are exacerbated by fatigue, which is one of the most pervasive and disabling symptoms in this. Fatigue in misses is both physical and cognitive, often described as a mental fog or an overwhelming sense of mental depletion that interferes with sustained concentration and task completion. Beyond cognitive dysfunction, misses exerts a profound emotional toll on patients. Depression is one of the most common psychiatric comorbidities, affecting up to 50s of individuals with misses at some point during their illness. This is not solely a psychological reaction to chronic illness, but is also thought to result from neurobiological changes, including inflammation, neurochemical imbalances, and lesions involved in mood regulation. Depression in misses can exacerbate cognitive deficits, reduce treatment adherence, and increase the risk of suicide, making early identification and management essential. Anxiety is also prevalent in misses, often co-occurring with depression. Patients may experience excessive worry about disease progression, uncertainty about the future, and social stigma. Cognitive symptoms, particularly memory lapses or word-finding difficulties, can increase self-consciousness and social withdrawal, further compounding emotional distress. In some cases, individuals may develop adjustment disorders or generalized anxiety disorder, which require tailored psychological and pharmacological interventions. Emotional lability or sudden and inappropriate mood changes can occur due to misses-related damage in brain regions responsible for emotional regulation. Some patients may exhibit pseudobulbar affect, characterized by uncontrollable episodes of laughing or crying unrelated to actual emotional experience. These symptoms are distressing and can be misinterpreted by others, contributing to social isolation and misunderstanding. Another important, yet often under-recognized, aspect is the impact of Mrs. on self-identity and psychological well-being. As cognitive and emotional changes accumulate, patients may struggle with a sense of lost competence or autonomy. This can affect self-esteem, interpersonal relationships, and overall life satisfaction. Coping with these changes often requires significant psychological adaptation and support. Management of cognitive and emotional symptoms in this involves a combination of pharmacological, psychological, and cognitive rehabilitation approaches. Disease-modifying therapies may slow cognitive decline by reducing lesion burden and brain atrophy. Cognitive rehabilitation programs, including compensatory strategies and computerized training, have shown promise in improving specific cognitive domains. Psychotherapy, particularly cognitive behavioral therapy, is effective for treating depression and anxiety and can enhance coping skills and resilience. Multidisciplinary care teams, including neurologists, neuropsychologists, psychologists, play a crucial role in addressing the multifaceted impact of disease. In conclusion, the cognitive and emotional impact of multiple sclerosis is substantial and often underappreciated. These non-motor symptoms can be as debilitating as physical impairments, affecting independence, relationships, and quality of life. Early assessment, comprehensive management, and personalized interventions are essential to support individuals living with MIS and to promote long-term cognitive and emotional health. Associated neurocognitive disorder and encompasses a spectrum of cognitive impairments affecting individuals living with HIV, despite the effectiveness of combination antiretroviral therapy. CART in controlling systemic viral replication and remains prevalent, with estimates suggesting that they experience some degree of cognitive dysfunction. These impairments can significantly impact daily functioning and quality of life. This and directory and is categorized into three primary conditions: asymptomatic neurocognitive impairment, mild neurocognitive disorder, and ANI is characterized by measurable cognitive deficits without overt functional impairment, and involves mild cognitive impairments that begin to interfere with daily activities, and represents the most severe form, marked by substantial cognitive decline and functional independence. The introduction of CARD has significantly reduced the incidence of HAID, making it relatively rare in regions with widespread access to treatment. However, ANI and MOND remain common, underscoring the need for ongoing attention to cognitive health in HIV-positive populations. Positive populations. The cognitive domains most frequently affected in HAND include attention, executive function, memory, psychomotor, speed, and information processing. Patients may experience difficulties in sustaining attention, organizing tasks, recalling information, and performing tasks that require rapid mental processing. These deficits can manifest subtly, making early detection challenging without formal neuropsychological assessment. The pathogenesis of HAND is multifactorial. Can directly infect the central nervous system, hence leading to neuroinflammation and neuronal injury. Additionally, chronic immune activation, co-infections, and comorbidities such as substance use disorders and cardiovascular disease can exacerbate cognitive decline. Certain antiretroviral medications may also have neurotoxic effects, further complicating the clinical picture. Diagnosis of HAND requires a comprehensive evaluation, including a detailed clinical history, neurological examination, and neuropsychological testing. It's essential to rule out other potential causes of cognitive impairment, such as depression, medication side effects, or other neurological conditions. Standardized criteria, like the Frascati criteria, provide a framework for classifying the severity of HAND based on cognitive testing and functional status. Management of HAND involves optimizing antiretroviral therapy to ensure effective genes penetration and control of viral replication. Addressing modifiable risk factors, such as managing cardiovascular health, treating co-infections, and supporting mental health, is also crucial. Cognitive rehabilitation strategies, including cognitive training and behavioral interventions, may offer benefits, although more research is needed to establish their efficacy in this context. In summary, there's a significant concern in the care of individuals with HIP, while severe dementia has become less common. Milder forms of cognitive impairment persist and can adversely affect daily functioning. Early recognition, comprehensive assessment, and a multifaceted management approach are essential to mitigate the impact of hand and improve outcomes for those affected. Cognitive rehabilitation after brain injury represents a critical aspect of neurohabilitation, aimed at restoring or compensating for impugnative functions and solving brain injuries, whether traumatic, TB, stroke, induced or due to hypoxia, often result in disruptions to neural circuits that underpin these cognitive domains. The variability in injury location and severity creates a highly individualized profile of cognitive deficits, necessitating a personalized, evidence-based thinking. Modern cognitive rehabilitation strategies operate on two main principles: restorative and compensatory. Restorative techniques seek to re-establish lost cognitive functions through repetitive exercises and neuroplastic training, aiming to strengthen residual neurogenesis or stimulate neurogenesis. Compensatory strategies, by contrast, focus on teaching individuals how to adapt to their deficits by developing alternative skills or using assistive technologies to bypass the damaged function. Attention training is a common starting point, as attentional deficits frequently accompany brain injuries and impact all other cognitive domains. Attention process training, ACT, one of the most widely used restorative protocols, involves hierarchically structured exercises that target sustained, selective, and divided attention. The rationale behind ACT is grounded in the theory that attention is a foundational cognitive function that can be incrementally rebuilt through targeted stimulation. This training is often supported by computerized cognitive training programs, which provide structured, adaptive, and quantifiable tasks designed to enhance attentional control. Memory rehabilitation employs both restorative and compensatory strategies. Memory for restorative approaches, spaced retrieval, vanishing cues, and errorless learning are utilized to rebuild declarative memory processes. These methods are particularly effective in patients with mild to moderate impairments, as they rely on repeated exposure and feedback to reinforce learning pathways. For more severe memory deficits, compensatory techniques such as external memory aids, ranging from notebooks and calendars to digital tools like smartphone apps, can substantially improve functional independence. Metacognitive training, which enhances awareness of memory limitations and teaches strategic problem solving, is another valuable intervention, especially for individuals with preserved insight. Executive function training is among the most challenging yet vital components of cognitive rehabilitation. Executive functions, encompassing planning, organization, inhibition, and flexible thinking, are often disrupted following frontal lobe injuries. Strategies to rehabilitate executive functioning typically combine direct skill training with contextualized, real-life applications. For instance, goal management training. It helps individuals break down complex tasks into manageable steps, while teaching techniques to monitor performance and adjust strategies in real time. This approach has shown promising results in improving task persistence and reducing everyday errors. This metacognitive strategy instruction underpins many successful cognitive rehabilitation approaches. This framework emphasizes the development of self-monitoring and self-regulation skills, allowing individuals to recognize cognitive breakdowns and apply strategies proactively. Techniques such as the stop-think, do-check sequence are designed to encourage reflective thinking and adaptive problem solving when implemented consistently. Metacognitive training can foster greater independence and transfer of skills to untrained tasks and settings. Technology plays an increasingly vital role in cognitive rehabilitation. Virtual reality. VR environments offer immersive and engaging platforms for practicing cognitive skills in ecologically valid scenarios, such as navigating a grocery stores. VR can simulate complex cognitive demands while allowing controlled manipulation of task difficulty. Similarly, neurofeedback and brain-computer interface systems are emerging tools that aim to enhance cognitive performance by providing real-time feedback on neural activity. Their concentration. The integration of multidisciplinary teams is essential for the success of cognitive rehabilitation programs. Neuropsychologists, occupational therapists, speech, language pathologists, and neurologists collaborate to conduct detailed assessments and implement individualized treatment. The use of standardized cognitive assessments before, during, and after intervention helps quantify progress and adjust treatment goals. Importantly, family involvement and education are key components of the rehabilitation process, as caregivers often facilitate strategy generalization into daily life. Despite advancements, challenges persist in cognitive rehabilitation. Variability in patient response. The influence of emotional and psychological factors, and access to specialized services remain barriers. Ongoing research is exploring biomarkers and predictive models to identify which patients are most likely to benefit from specific interventions, aiming for more targeted and efficient rehabilitation protocols. In conclusion, cognitive rehabilitation after brain injury is a dynamic, evidence-driven field that blends neuroscience, psychology, and technology to address the diverse cognitive deficits arising from neural insult. By combining restorative techniques with adaptive strategies and leveraging interdisciplinary collaboration, cognitive rehabilitation offers individuals the potential to regain autonomy and reintegrate into their communities. As our understanding brain plasticity and individual variability deepens, so too will the precision and effectiveness of these life-changing interventions. Cognitive reserve is a theoretical construct that explains individual differences in resilience to brain aging and pathology. It refers to the brain's ability to optimize or maximize performance through differential recruitment of brain networks, or the use of alternative cognitive strategies, despite similar levels of brain atrophy or neuropathological burden. Individuals with higher cognitive reserve often exhibit fewer clinical symptoms or a delayed onset of cognitive decline. This concept has significantly shifted our understanding of aging, emphasizing not only biological degeneration, but also the role of life experiences, education, and intellectual engagement. The origins of cognitive reserve theory lie in observations from neuropathological studies. Autopsy findings from elderly individuals who had shown no signs of dementia during life often revealed significant Alzheimer's disease pathology. Conversely, some individuals with noticeable cognitive impairment exhibited relatively minimal brain changes. These inconsistencies suggested that some brains were better equipped to tolerate damage than others. The concept of cognitive reserve emerged to account for these differences, proposing that the efficiency, capacity, and flexibility of cognitive practices buffers against clinical decline. Education is one of the most consistent predictors of cognitive reserve. Numerous epidemiological studies have shown that higher levels of formal education are associated with a reduced risk of developing dementia, even when accounting for age, socioeconomic status, and other health-related variables. However, education is not the sole contributor. Occupational complexity, bilingualism, literacy, and lifelong participation in intellectually stimulating activities such as reading, playing musical instruments, or engaging in social interactions. Although cognitive reserve, these activities are thought to promote the development of richer, more adaptable neural networks, capable of compensating for damage or inefficiency in aging brains. Neuroimaging research has provided direct evidence supporting the neural basis of cognitive reserve. Functional memory studies have shown that individuals with higher cognitive reserve often activate different or more extensive brain networks than those with lower reserve when performing cognitive tasks. For example, they may recruit bilateral rather than unilateral regions, or utilize frontal regions more effectively to support memory or executive functions. These patterns reflect not only compensatory mechanisms, but also potentially more efficient use of neural resources. Structural imaging has also shown that people with high reserve tend to maintain greater brain volume and white matter integrity. Although these are not the sole determinants of resilience, cognitive reserve also plays a crucial role in how individuals respond to brain injury or neurodegenerative diseases. In Alzheimer's disease, for example, patients with higher reserve may experience a longer preclinical phase where pathology accumulates silently before symptoms emerged. Once symptoms do appear, the decline may be more rapid due to the greater underlying burden, but the extended period of functional independence significantly improves quality of life. Similarly, in stroke and traumatic brain injury, higher cognitive reserve is often associated with better recovery outcomes and a more favorable trajectory of rehabilitation. The role of cognitive reserve in normal aging is equally important. Even in the absence of disease, aging is associated with declines in processing speed, working memory, and executive function. However, these declines are neither inevitable nor uniform. Older adults with high cognitive reserve often maintain superior cognitive functioning well into late life. This has led to growing interest in lifestyle interventions aimed at enhancing reserve across the lifespan. Physical exercise, cognitive training, social engagement practices have all been proposed as means to bolster cognitive reserve, either by promoting neural networks, enhancing neural networks. Importantly, cognitive reserve is not static. It can be developed and maintained throughout life, suggesting that interventions at any age can be beneficial. This notion aligns with a broader framework of brain maintenance and brain plasticity, wherein environmental and behavioral factors shape cognitive trajectories. In this sense, cognitive reserve represents both a protective factor and a target for public health strategies aimed at reducing the burden of cognitive aging and, in sum, cognitive reserve provides a powerful explanatory model for individual differences in cognitive aging and the clinical expression of brain pathology. It highlights the interplay between brain biology and life experience, underscoring the importance of lifelong learning, engagement, and adaptability as populations age worldwide. Understanding and enhancing cognitive reserve will be essential for promoting healthy cognitive aging and mitigating the impact of neurodegenerative diseases. Neuropsychological assessment aims to evaluate cognitive, emotional, and behavioral functioning, often to diagnose or guide treatment for neurological or psychiatric conditions. However, the validity and fairness of such assessments are significantly influenced by cultural factors. Culture shapes an individual's experiences, language, education, and values, all of which can profoundly impact test performance and interpretation as the world becomes increasingly multicultural. Clinicians must address these cultural variables with sensitivity and scientific rigor to avoid misdiagnosis, stigma, and inequity. Culture influences neuropsychological assessment at multiple levels. Language is perhaps the most overt, as many neuropsychological tests rely heavily on verbal comprehension, expression, and memory. Administering tests in a person's non-native language or translating instruments without cultural adaptation risks introducing errors unrelated to cognicity. Even when assessments are conducted in a native language, dialectal variations, idioms, and culturally specific meanings can alter test interpretation. Moreover, language proficiency is not binary. Individuals may have conversational fluency, but struggle with abstract or academic vocabulary, leading to underperformance. Beyond language, educational background is another critical cultural variable. Years of formal education are often used as a proxy for cognitive reserve and intellectual ability, but this overlooks disparities in educational quality and cultural and national contexts. A person educated in a rural school with limited resources may have different cognitive strategies and problem-solving styles compared to someone educated in a well-funded urban the same number of school years. This makes direct comparisons using standardized norms problematic. Socioeconomic status, which is closely linked to both culture and education, also affects cognitive test outcomes. Chronic stress, undernutrition, and lack of access to stimulating environments during childhood can all contribute to differences in neurodevelopment, which are later reflected in test performance. These factors are not indicators of brain dysfunction, but rather contextual influences that must be distinguished from true neurological impairment. Cultural values and norms shape not only cognition, but also the test, taking experience itself. In some cultures, quick responses and assertiveness may be encouraged and interpreted as signs of intelligence, while in others they are valued. Individuals from collectivist societies may approach tasks differently than those from individualistic cultures, prioritizing harmony over self-expression or avoiding behaviors perceived as boastful. These cultural orientations can impact motivation, risk-taking, and response style during assessments, potentially skewing results if not accounted for in interpretation. A related challenge lies in the development and standardization of neuropsychological tests. Many widely used assessments were normed on Western, educated, industrialized, rich, and democratic, weird populations, which do not represent the cognitive profiles or experiences of most of the global population. Applying these norms indiscriminately can result in systematic underestimation of cognitive abilities in individuals from different backgrounds. To address this, researchers have developed culturally specific normative data for various regions and language groups, but such resources remain limited and are often inaccessible in clinical practice. Clinicians must adopt a culturally competent framework when conducting neuropsychological assessments. This begins with an awareness of their own cultural biases and the potential influence these may have on their perceptions and interpretations. It involves taking a thorough cultural and linguistic history as part of the assessment process, including details about the patient's language proficiency, educational experiences, a cultural identity. This contextual information is crucial for making informed judgments about test performance. In some cases, selecting culturally adapted tests or using nonverbal measures of cognitive ability may help reduce cultural bias. For example, tests that assess visuospatial skills, pattern recognition, or working memory with minimal language demands can offer a more equitable view of cognitive function across culture. Nevertheless, Even nonverbal tests are not entirely culture-free, as familiarity with test taking conventions, abstract reasoning styles, and exposure to certain stimuli can vary across groups. In addition to test selection, interpretation must be culturally sensitive. Scores should be understood within the context of the individual's background, and clinicians should be cautious not to overpathologize deviations from normative expectations. Collaborative consultation with culturally informed colleagues or bilingual specialists can enhance the accuracy of assessment outcomes. Ultimately, cultural competence in neuropsychological assessment is not an ancillary consideration, but a fundamental requirement for ethical and valid practice. By integrating cultural awareness, scientific rigor, and individualized understanding, neuropsychologists can ensure that their assessments honor the diversity of human experience. This is particularly vital in an era of increasing cultural heterogeneity, where the demand for equitable and inclusive mental health services continues to grow. Developmental neuropsychology is a field that explores the relationship between brain development and cognitive, emotional, and across the lifespan. It examines how the maturation of neural structures supports the emergence of complex abilities, such as language, memory, executive function, and social cognition. Central to this field is the understanding that brain development is not uniform, but follows a dynamic, regionally specific, and experience-dependent trajectory that shapes and environment. Brain maturation begins in utero and continues into early adulthood, with distinct timelines for different regions and systems. In infancy and early childhood, the brain undergoes rapid growth, characterized by neurogenesis, synaptogenesis, and myelination. These processes support early sensory and motor development and lay the foundation for more advanced cognitive skills. For example, the maturation of the occipital lobes enables visual processing in infancy, while the development of sensorimotor areas supports locomotion and eye coordination. During early childhood, the brain experiences a period of exuberant synaptogenesis, where the number of synaptic connections far exceeds those in the adult brain. This overproduction is followed by synaptic pruning, a process whereby unused or redundant connections are eliminated. Pruning increases the efficiency of neural networks and is guided by both genetic programming and environmental input. This reflects the principle of use it or lose it, where experiences during critical periods of development shape neural architecture in lasting ways. Myelination, the process by which axons are insulated with a fatty sheath to speed up neural transmission, progresses in a regionally specific pattern, beginning in sensorimotor and extending in restorative and the prolonged maturation of the prefrontal cortex, which continues into the mid-20s, corresponds with the gradual emergence and refinement of executive functions such as planning, impulse control, and decision-making. These skills are essential for goal-directed behavior and adaptive functioning, and are among the last to reach adult levels of proficiency. Language development provides a clear example of the interplay between brain maturation and cognitive function. The left hemisphere, particularly Broca's and Wernicke's areas, undergoes rapid development during early childhood, coinciding with the critical period for language acquisition. During this window, children are especially sensitive to linguistic input, and disruptions due to brain injury or deprivation can have lasting effects. However, the plasticity of the developing brain also allows for remarkable recovery in some cases, with undamaged regions sometimes compensating for early lesions. Memory systems also follow a developmental trajectory. The hippocampus, critical for forming episodic memories, matures gradually over the first why most individuals cannot recall events. Phenomenon known as infantile amnesia. As this system matures, children become capable of forming long-term memories with increasing specificity and organization. The interaction between the hippocampus and prefrontal cortex becomes increasingly important for strategic memory use and retrieval in later childhood and adolescence. Social cognition and emotional regulation are heavily influenced by the maturation of limbic and cortical circuits. The amygdala, involved in processing emotional stimuli, is functionally active early in life, but its regulatory interactions with the prefrontal cortex evolve over time. This developmental mismatch, where subcortical emotional systems mature earlier than prefrontal control systems, helps explain the heightened emotional reactivity and risk. The ongoing development of these circuits supports improved empathy, perspective taking, and social reasoning. Developmental neuropsychology also investigates how atypical brain development contributes to neurodevelopmental disorder. Conditions such as attention deficit hyperactivity disorder, autism spectrum disorder, ASD, and specific learning disabilities of brain maturation and, for example, children with AD often show delayed cortical thinning, particularly in the prefrontal cortex, which may underlie their executive function deficits. Similarly, structural and functional differences in connectivity patterns are observed in ASD, affecting social and communicative development. Research in this field relies on longitudinal neuroimaging studies, cognitive testing, and behavioral observations to track development over time. Functional MRI, EEG, and diffusion tensor imaging have provided valuable insights into how structural and functional connectivity changes across age and how these changes relate to cognitive milestones. These methods allow for the identification of sensitive periods for intervention and inform educational and clinical strategies tailored to the developmental stage. In conclusion, developmental neuropsychology provides a comprehensive framework for understanding how brain maturation shapes cognitive and emotional development. It highlights the intricate timing and plasticity of neural systems and underscores the importance of early experiences in sculpting brain architecture. This knowledge is crucial for identifying atypical development, guiding interventions, and supporting optimal outcomes across the lifespan. Neuropsychological testing is a vital tool in assessing cognitive, emotional, and behavioral functioning related to brain health. It plays a central role in diagnosing neurological disorders, guiding treatment planning, and informing legal or occupational decisions. However, the use of these powerful tools brings a range of ethical challenges that must be rigorously addressed to uphold professional integrity, patient welfare, and societal trust. Ethical considerations in neuropsychological testing encompass issues of informed consent, test validity, cultural fairness, confidentiality, and the potential for misuse of results. One of the most foundational ethical requirements in neuropsychological testing is obtaining informed consent. This involves more than a signature on a form. It requires ensuring that the individual fully understands the nature, purpose, and potential outcomes of the assessment. This can be particularly complex when working with individuals who have cognitive impairments, such as dementia or traumatic brain injury. which may affect their capacity to provide consent. In such cases, clinicians must assess decision-making capacity and involve legal guardians or proxies as necessary, while striving to respect the autonomy and dignity of the greatest extent possible. Test selection and administration must be based on sound scientific principles and the specific needs of the individual. Ethically, clinicians are obligated to use instruments that are validated for the populations they assess and to interpret results within the context of the individual's demographic and linguistic. The inappropriate use of norm-referenced data, particularly when applying norms derived from populations dissimilar to the test taker, can lead to misdiagnosis. This concern is particularly acute in cross-cultural assessments, where language barriers, educational disparities, and cultural variations in test taking behavior can significantly influence. Clinicians must be trained to recognize and adjust for these factors, and, when necessary, employ culturally adapted tests or consult with experts in multicultural assessment. Another major ethical issue involves confidentiality and the sensitive nature of the information obtained through neuropsychological testing. These assessments can reveal deeply personal information about cognitive strengths and weaknesses, mental health status, personality traits, and even potential for future decline. The storage, sharing, and interpretation of this data must adhere strictly to privacy regulations, such as HIPAA in the United States. Particular caution is warranted when test results are shared with third parties, such as employers, insurance companies, or the legal system, as the implications can be significant and potentially life-altering. Consent for disclosure must be obtained explicitly, and clinicians must advocate for the appropriate use of findings, especially when misuse could result in discrimination or harm. The potential for dual roles and conflicts of interest also presents ethical challenges in neuropsychological testing. For example, the clinician may be asked to assess a patient for both clinical care and legal competency. These dual roles can compromise objectivity and erode trust. Ethical guidelines recommend clear boundaries and, where possible, separation of roles to prevent bias or the perception thereof. When a neuropsychologist serves as an expert witness in legal settings, the responsibility to provide impartial evidence-based testimony takes precedence over advocacy for either party. Feedback and communication of results constitute another ethical frontier in neuropsychological testing. patients have the right to receive clear, compassionate, and understandable feedback about their test outcomes. Clinicians must be careful not to overstate the precision or implications of the findings and should avoid deterministic language, especially in cases that may carry significant psychosequences. Feedback should also be tailored to the patient's level of understanding and emotional readiness, and should ideally include practical recommendations for treatment, support, or accommodations. The rise of computerized and remote neuropsychological assessments introduces new ethical considerations related to test security, standardization, and equitable access. While digital tools offer convenience and scalability, they may also pose challenges in ensuring consistent administration and safeguarding test materials. Furthermore, disparities in digital literacy or internet access can exacerbate existing inequities in who receives high-quality assessments. Finally, ethical practice in neuropsychological testing demands a commitment to ongoing professional development. As the field evolves, clinicians must stay abreast of new research, revisions to testing standards, and shifts in ethical guidelines. This includes reflecting on their own biases and limitations, seeking supervision or consultation when needed, and engaging in peer review or continuing education to ensure competence. In sum, ethical issues in neuropsychological testing are deeply intertwined with the power and sensitivity of the assessments themselves. Maintaining ethical integrity requires a thoughtful, patient-centered approach that respects individual rights, recognizes the diversity of human experience, and safeguards the responsible use of psychological knowledge. By doing so, neuropsychologists uphold the trust placed in them by patients, families, and society at large. Executive dysfunction is a hallmark of frontal lobe syndromes, reflecting the breakdown of higher-order cognitive processes essential for goal-directed behavior. The frontal lobes, particularly the prefrontal cortex, are responsible for orchestrating a wide array of executive functions, including planning, decision-making, cognitive flexibility, inhibition, and working memory. Damage to these regions, whether from traumatic brain injury, stroke, tumors, neurodegenerative diseases, or developmental disorders, can severely disrupt an individual's capacity to regulate thoughts, emotions, and behavior in an adapt. While the specific presentation varies, depending on the exact location and extent of the lesion, executive dysfunction generally reflects impaired coordination between the feci and subcortical structures including the basal ganglia, thalamus, and limbic system. The prefrontal cortex is anatomically and functionally heterogeneous. The dorsolateral prefrontal cortex is crucial for working memory, abstraction, and cognitive control. The orbitofrontal cortex, OC, modulates decision-making, particularly in situations involving reward and punishment. The ventromedial prefrontal cortex, VAMFC, overlapping with the OFS, is involved in social cognition, emotional regulation, and value-based choices. Damage to any of these subregions results in a distinct profile of executive impairment, highlighting the modularity of frontal lobe functions. DOF lesions, for example, often lead to difficulties in organizing information, maintaining task goals, and shifting cognitive sets. Individuals may exhibit poor problem-solving skills, perseverative responses, and an inability to adapt to new rules or environments. Features often psychological tools. The Stroop test. In contrast, lesions to the off-core VAMFC disrupt inhibitory control and the ability to assess risk and reward. Patients may present with socially inappropriate behavior, impulsivity, or a marked lack of insight into their actions, despite having intact general language. This phenomenon, sometimes referred to as pseudopsychopathy, reflects the breakdown of connections between the frontal cortex and the limbic system, particularly the amygdala, leading to impaired emotional decision-making. The classic case of Phineas Gage, who suffered a massive OC injury following a railroad accident, remains one of the earliest and most illustrative examples of how focal damage to causality changes and poor executive control. Another common manifestation of executive dysfunction in frontal lobe syndromes is impaired initiation and goal formation, which can give rise to apathy or abulia. These conditions, more often associated with damage to the medial prefrontal and anterior cingulate regions, are characterized by diminished motivation, lack of spontaneous behavior, and a failure to engage in purposeful activity. Importantly, such symptoms are not due to motor deficits or depression per se, but rather to its connection between intention and action planning mechanisms in the brain. Frontal lobe syndromes are also a central feature of various neurodegenerative disorders. In frontotemporal dementia, particularly the behavioral variant, profound executive dysfunction often appears early and dominates the clinical picture. these individuals may demonstrate impaired judgment, emotional blunting, compulsive behavior, and a profound inability to manage daily tasks. Neuroimaging typically reveals atrophy in the orbitofrontal and medial frontal cortices, correlating with the behavioral and cognitive symptoms. Similarly, Parkinson's disease and Huntington's disease, both involving frontostriatal circuits, can lead to secondary executive dysfunction, even in the absence of overt cortical lesions. In these cases, the dopaminergic modulation of prefrontal networks is disrupted, affecting planning and working memory performance. Traumatic brain injury, TB, especially in closed head injuries, often results in diffuse axonal damage with a predilection for frontal networks. Post-injury, patients may struggle with attention, planning, and social appropriateness, even when basic cognitive abilities are preserved. Rehabilitation of executive function following TBI stroke requires targeted interventions that address the hierarchical nature of goal. Directed behavior, often involving external regulation, and Importantly, executive dysfunction does not manifest in isolation, but interacts with emotional, social, and motivational systems, creating a complex clinical picture. A patient may simultaneously experience cognitive rigidity, emotional disinhibition, and apathy, each rooted in distinct but overlapping prefrontal circuits. Neuropsychological assessment thus requires a multi-domain approach, integrating behavioral observation with formal testing. This allows clinicians to disentangle deficits in initiation, planning, and monitoring from other conditions, such as mood disorders or primary psychosis. In sum, executive dysfunction in frontal lobe syndromes represents a breakdown in the capacity to think ahead, inhibit inappropriate responses, flexibly adapt to change, and regulate social behavior. It reflects disruption in a distributed neural network centered on the prefrontal cortex and its connections to subcortical and limbic structures. The specific nature of executive impairments depends on the location of the damage within the frontal lobes, the underlying etiology, and the individual's premorbid functioning. Understanding these patterns is crucial for accurate diagnosis, prognosis, and the development of targeted therapeutic strategies to support functional independence and quality of life. Would you like a version of this essay with references to peer-reviewed studies and papers? damage to the frontal lobe, particularly its prefrontal regions, has profound implications for executive function. A suite of high-level cognitive processes that enable problem-solving conduct. The frontal lobes, which constitute roughly 1/3 of the cerebral cortex, serve as the control center for integrating information. Their impairment can lead to dramatic and often debilitating changes in personality, cognition, and adaptive functioning, even when basic sensory and motor functions, executive functions, are not singular processes, but a constellation of interrelated abilities, including working memory, inhibitory control, cognitive thinking. The dorsolateral prefrontal cortex, DOFC, is heavily implicated in tasks requiring strategic planning, sustained attention, and working memory manipulation. Damage to this area often results in disorganized thinking, difficulty maintaining focus, and poor problem-solving skills. Individuals may appear apathetic, unable to initiate tasks, or may struggle to hold information in mind long enough to carry out multi-step activities, even if their memory for past events is otherwise preserved. The orbitofrontal cortex, OC, another key subregion of the frontal lobe, plays a central role in regulation, reward processing, and social behavior. Lesions here are associated with disinhibition, impulsivity, and inappropriate social conduct. A classic example is the inability to suppress socially unacceptable comments or behavior, despite understanding social norms. These changes are not simply behavioral, but reflect impaired judgment and altered risk. Reward assessment. Patients may make decisions that are risky or maladaptive, demonstrating a loss of insight into the consequences of their actions. This phenomenon, often termed dysexecutive syndrome, can lead to significant functional impairment, despite preserved intellect. Medial frontal regions, including the anterior cingulate cortex, are involved in motivation and the monitoring of actions and errors. Damage here may result in abulia, a profound lack of will or initiative. Such individuals are not simply depressed or fatigued. Rather, they may lack the intrinsic drive to engage with their environment. In more severe cases, this can progress to akinetic mutism, in which the person is alert, but almost completely passive. either moving or speaking, unless strongly prompted. The assessment of executive function deficits following frontal lobe injury often relies on neuropsychological testings. Tasks such as the Wisconsin card sorting test, the Stroop task, and the Tower of London measure cognitive flexibility, inhibition, and planning, respectively. These tests reveal how patients struggle to shift strategies, suppress automatic responses, or sequence actions to achieve a goal. Difficulties that may not be immediately evident in casual conversation, but critically disabling in real-world functioning. Importantly, the impact of frontal lobe damage on behavior is modulated by factors such as lesion size and location, premorbid personality, and environmental support. Lesions sustained early in life can disrupt the normal development of executive systems, leading to lifelong difficulties with self-regulation and social adaptation. In contrast, adults with well-developed executive function may show remarkable resilience, especially with appropriate rehabilitation. Neuroimaging studies have deepened our understanding of the frontal lobes by illustrating their involvement in distributed networks rather than isolated regions. Functional MRI has shown that even simple tasks engage widespread prefrontal areas, depending on task demands and individual strategies. These findings support the idea that executive functions are emergent properties of coordinated activity across multiple neural systems, including ear and cerebellum. Rehabilitation following frontal lobe damage is complex and often requires an interdisciplinary approach. Cognitive rehabilitation therapy focuses on retraining specific executive skills or teaching compensatory strategies. For example, individuals with planning deficits may benefit from external aids like checklists, timers, or structured routines. Psychotherapy can also be critical, especially in helping patients and caregivers adapt to personality changes and emotional dysregulation. In some cases, pharmacological treatments such as stimulants or antidepressants are used to address symptoms like apathy or impulsivity, though their efficacy varies. Ultimately, the effects of frontal lobe damage on executive function illustrate the central role these brain regions play in shaping our behavior, personality, and ability to navigate life. While deficits in memory or perception can be challenging, impairments in executive function strike at the core of autonomy and self-control. Understanding these consequences is essential not only for clinical care, but also for broader insights into the neurological basis of human behavior. Language processing in the human brain is one of the most intricate and remarkable examples of neural specialization. The Wernicke Broca model, a foundational framework in neurolinguistics, has long served as a basis for understanding how our brains enable the complex task of producing and comprehending language. This model, developed in the 19th century, centers around two core regions in the left hemisphere of the brain. Broca's area, traditionally associated with language production, and Wernicke's area, linked to language comprehension. While modern neuroscience has since refined and extended this model, its foundational concepts remain crucial for interpreting both normal language function and language disorders. Language disorders. Broca's area is located in the posterior, inferior frontal gyrus of the dominant, usually left, named after the French physician Paul Broca, who discovered the region in patients with expressive aphasia. This area is critical for speech production and grammatical structuring. Patients with Broca's aphasia typically exhibit halting, effortful speech with poor grammar, but retain relatively preserved comprehension. This suggests that Broca's area is more involved in the motor planning and syntactic aspects of language than in semantic processing. In contrast, Wernicke's area is situated in the posterior part of the superior temporal gyrus. Carl Wernicke identified this region in patients who could speak fluently, but whose speech lacked meaning, and whose comprehension was severely impaired, a condition now known as Wernicke's aphasia. These patients often produce grammatically correct sentences that are semantically incoherent, illustrating the area's role in understanding language and mapping sounds to meaning. The classic Wernicke Broca model proposes a unidirectional sequential processing path, where spoken words are first decoded in Wernicke's area and then transmitted via the arcuate fasciculus, a bundle of white matter. This model was revolutionary in establishing the localizationist view of brain function, emphasizing specific regions for specific cognitive tasks. It offered a compelling explanation for many aphasic syndromes and paved the way for later models of cortical specialization. However, subsequent neuroimaging studies and lesion analyses have revealed that this model is an oversimplification. Language processing involves a much more distributed network across both cortical and subcortical regions. For instance, the anterior temporal lobe has been implicated in semantic memory and the comprehension of complex sentences, while the basal ganglia and cerebellum contribute to timing and fluency in speech. Additionally, the notion of strict left hemisphere dominance has been nuanced by findings showing significant right hemisphere contributions, especially in aspects such as prosody, emotional tone, and metaphorical language. Moreover, the discovery of functional neuroimaging and electrophysiological techniques has allowed researchers to track the dynamic interplay between brain regions during language tasks. These studies reveal that language comprehension and production involve bidirective processing between multiple areas, rather than a simple relay from Wernicke's to Broca's regions. The dual-stream model of language, for example, posits a ventral stream that processes speech, recognition, and semantic understanding, and a dorsal stream that maps sound to articulation. This model incorporates both the classical areas and additional regions, offering a more anatomically and functionally accurate representation of the language network. Despite these advances, the Wernicke-Broca model remains historically and pedagogically significant. It provides a foundational lens through which more complex models are understood and continues to inform clinical approaches to diagnosing and treating aphasia. For instance, damage to Broca's area is still reliably associated with non-fluent aphasia, while lesions in Wernicke's area correlate with fluent but nonsensical speech patterns. These correlations are not absolute, but they are clinically useful in guiding speech, language therapy, and neurological assessment. In clinical neuroscience, the legacy of the Wernicke-Broca model is further evident in the use of functional mapping during neurosurgery. Surgeons often rely on knowledge of these classical areas to avoid impairing essential language functions during tumor resections or epilepsy surgery. Techniques like direct cortical stimulation during awake craniotomy directly test regions' involvement in language tasks, confirming the importance of the Wernicke and Broca areas while also revealing individual variability. Ultimately, the understanding of language processing has evolved from the discrete localizationism of the Wernicke-Broca model to a more nuanced view that incorporates dynamic network-based interactions. While the model has limitations in light of current evidence, it provided the essential scaffolding upon which modern theories of language neurobiology were built. Appreciating both its contributions and its constraints allows us to better grasp the complexity of how the human brain enables language, a uniquely human faculty, at shaped lateralization of brain function refers to the specialization of certain cognitive processes in either the left or right hemisphere of the brain hemisphere of the brain. While both hemispheres are structurally similar and interconnected by the corpus callosum, they exhibit functional asymmetries that allow for efficient processing and coordination of complex tasks. This division of labor does not imply that one hemisphere works in isolation. Rather, it highlights the brain's ability to optimize performance by distributing different types of regions. The left hemisphere is traditionally associated with language and analytical thinking. It plays a dominant role in speech production, grammar, and comprehension, particularly in right-handed individuals. Broca's area, located in the posterior inferior frontal gyrus, and Wernicke's area, situated in the posterior superior temporal gyrus, are two critical language centers, typically lateralized to the left hemisphere. Damage to these regions can result in various forms of aphasia, reinforcing the left hemisphere's role in linguistic abilities beyond language. The left hemisphere also excels in logical reasoning, mathematical computations, and sequential processing, making it essential for tasks and rule-based operations. In contrast, the right hemisphere is more involved in visuospatial processing, attention, and holistic or integrative functions. It contributes to the perception of spatial relationships, facial recognition, and processing of music and nonverbal cues. The right hemisphere also plays a significant role in emotional expression and the interpretation of tone, prosody, and context in language, abilities necessary for humor and metaphor. Additionally, it is more involved in sustained attention and awareness of global patterns rather than fine details, contributing to creative and intuitive problem solving. One of the most striking demonstrations of hemispheric specialization comes from studies of patients who have undergone corpus callosotomy, a surgical procedure that severs the corpus callosum to treat intractable epilepsy. In these split brain patients, each hemisphere operates largely independently, providing researchers a unique opportunity to study their individual contributions. For example, when visual information is presented to the left visual field, processed by the right hemisphere, patients may be able to draw the object with their left hand, but unable to name it. Accesses language centers. Hemispheric lateralization also influences motor and sensory functions. Each hemisphere controls the opposite side of the body. The left hemisphere governs movement and sensation on the right side, and vice versa. This contralateral control is due to the crossing of motor and sensory pathways in the brainstem. As a result, strokes or injuries in one hemisphere often produce deficits on the contralateral side of the body. The clinical relevance of this is evident in neurological assessment and rehabilitation, where understanding the side of brain damage helps predict functional impairments. Despite the clear evidence of functional asymmetries, the concept of hemispheric dominance should not be oversimplified. Popular culture often promotes the idea of left-brained logical people and right creative people. But this dichotomy is a misconception. In reality, most cognitive functions involve interhemispheric communication and collaboration. Even tasks with lateralized dominance, such as language, engage homologous areas in both hemispheres to varying degrees. For instance, while the left hemisphere may handle the syntactic structure of language, the right hemisphere contributes to understanding emotional tone and metaphorical content. The degree of lateralization can also vary among individuals. Left-handed people, for example, are more likely to exhibit atypical language lateralization, with some showing bilateral or right hemisphere language dominance. Moreover, developmental and neurological conditions can influence lateralization. For example, children with developmental language disorders or individuals with autism spectrum disorder may display altered patterns of hemispheric activation, reflecting atypical lateralization. Advances in neuroimaging techniques, such as functional MRI and diffusion tensor imaging, have greatly enhanced our understanding of lateralization by allowing real-time observation of activity. These tools confirm that while lateralization enhances processing efficiency by minimizing redundancy, the brain maintains a high degree of plasticity and redundancy. In conclusion, the lateralization of brain function is a fundamental aspect of neural organization that enhances cognitive efficiency and specialization. The left hemisphere is more engaged in language and analytical reasoning, while the right hemisphere excels in visuospatial and emotional processing. However, these distinctions exist within a broader framework of interhemispheric cooperation, underscoring the brain's integrative and dynamic nature. Recognizing both the strengths and limitations of hemispheric specialization is crucial for understanding brain function, guiding clinical practice, and dispelling enduring